Hello, and thank you for joining us for this session, Racial Disparities in Ovarian Cancer. We'd like to thank our sponsor, GSK, for making this session possible. From the point of diagnosis through treatment, racial disparities in ovarian cancer exist and disproportionately impact Black women. Our speaker, Dr. Dineo Khabele, will discuss this important issue and what we can do about it. Dr. Dineo Khabele is the Mitchell and Elaine Yanow Professor and the Chair of the Department of Obstetrics and Gynecology at Washington University School of Medicine in St. Louis, Missouri. You can view her full bio in the downloadable conference program. Thank you so much for joining us, Dr. Khabele, and I'll now turn it over to you.
I'd like to thank the OCRA for inviting me to talk about racial inequities in ovarian cancer focused on Black women. Here are my disclosures, and the opinions here are all my own. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. This is one of my favorite quotes from the Reverend Dr. Martin Luther King Jr., and it resonates with me because I feel that if we are able to take care of some of the injustices and the inequities in healthcare, we will be able to help everybody. If we can help the most vulnerable of us, that makes all our care better. So I'm going to tell you a few stories to illustrate why this is so important, and then give you a background of some of the history. So the first story is about a 48-year-old Black woman who had sought care for almost a year, 12 months, for abdominal pain and pressure. She felt a mass in her belly, and she was told she'd had fibroids because fibroids are so common amongst Black women. They're actually common amongst women in general, but there is a myth in medicine that they're far more common amongst Black women. Eventually, she went to a gynecologist who also felt a large mass, and she underwent imaging that discovered a large complex mass with cystic and solid components. They drew a blood test, and she was found to have an elevated CA-125. So these two pieces of information led her to be referred to a gynecologic oncologist. She was eventually diagnosed with a stage 3A ovarian cancer, but her diagnosis had been delayed. Fortunately, she received standard of care treatment, and she's currently alive with no evidence of disease. The second story is about a 39-year-old Black woman who is in good health, yearly visits to her gynecologic and primary care physicians. She actually had a family history of breast and ovarian cancer, and she was referred for testing after one of her cousins was diagnosed with ovarian cancer. She was found to have a BRCA1 mutation and underwent a risk-reducing hysterectomy, bilateral salpingo-oophorectomy, because she was done with childbearing, and she decided that this was important to reduce her risk. But what's interesting about her story is, despite the fact she'd had this family history of breast and ovarian cancer, she'd never really been counseled that she herself could have been at risk. And the only reason she was tested was because her cousin had ovarian cancer. So I tell these stories to talk about the fact that we know that if we provide the best ovarian cancer care through risk reduction, diagnosis, treatment, survivorship, and palliative care, women live longer. With increased genetic testing and interventions, we're able to reduce the risk of ever developing ovarian cancer. We know now that women diagnosed even with advanced stages of ovarian cancer have far more treatment options than they ever had before, and that women, in fact, are living longer with the diagnosis of ovarian cancer. Despite the fact that ovarian cancer is the deadliest gynecologic malignancy, we are doing better, and we want to make sure that all women have access to equal care. Unfortunately, there are stark inequities in ovarian cancer. Although ovarian cancer is far more common amongst white women, in general, the risk of ovarian cancer is 1 in 78 women. There are far worse outcomes. And evidence suggests that equal care will lead to equal outcomes for Black women, but unfortunately, many Black women diagnosed with ovarian cancer do not receive equal care. This inequity goes beyond ovarian cancer care. We know that we have a problem across healthcare. Black patients are less likely to receive appropriate cardiac medication, less likely to undergo coronary artery bypass surgery, more likely to be diagnosed with late-stage breast cancer and ovarian cancer, more likely to receive a lower quality of basic clinical services such as intensive care. And we know that there are stark racial inequities in death. Right now, in the middle of the COVID pandemic, nationwide, Black people are dying at 2.5 times the rate of white people. We know, related to women's health and pregnancy, that Black women are far more likely to die from pregnancy-related complications than other women in this country. When we look at leading causes of death by sex among Blacks and whites, the data was published last year and reflects information from 2016. We see that prior to COVID, heart disease and cancer were the leading causes of death amongst Black and white men and women. And there are stark differences in death rates. Black people are more likely to die from cancer than white people. When we look at gynecological cancers, if we look across the board from cervical cancer, uterine cancer, and ovarian cancer, 5-year survival rates for Black women are far lower than they are for white women and for women from all races. And so this is a huge problem across healthcare and includes gynecological cancers and ovarian cancer. So with race, COVID-19, and cancer, what we know, we've already talked about that COVID-19 has increased risk of, you have an increased risk of being infected by COVID if you're Black, and increased risk of dying. A recent study just came out that showed that you had a decreased likelihood to receive treatment with remdesivir, which is one of the few treatments available for COVID if you were Black. So this is the underlying problem that we're faced with, and it's not new. The Institutes of Medicine, National Academies published this landmark paper in 2003, confronting racial and ethnic disparities in healthcare. And what's really important is we all know that there are differences and we have personalized healthcare that's going to target particular treatments to an individual. And that's really not what I'm talking about, and not what we're discussing here. We're not talking about the clinical appropriateness or patient preferences. What we're talking about is disparities, the ecology of the healthcare system, environmental factors, and discrimination, racism, stereotyping, that really impacts the differences, the disparities and inequities we see in healthcare. So if we talk about disparities, let's start with systemic factors. Some of them have to do with basic things like geography. Where a person lives, a person's zip code can determine the type of care they have access to. Whether you have a hospital system that takes care of a lot of patients with your particular disease or condition, so a low volume hospital or catchment area, and inadequate insurance policies, the lack of Medicaid coverage of clinical trials, for instance, could limit access to care. And that's really been changing in cancer care in recent years. And we know that the states that have expanded Medicaid coverage have improved access to cancer care. So the strategies to address these disparities, in part, are to partner with specialized regional referral centers, and to have access to care locally, but also to expand insurance policies to limit financial toxicity of care. Those are just some examples of how we can address systemic factors. Physician factors include being a low volume surgeon, working in a hospital that doesn't see, or a clinic that doesn't see as many patients diagnosed with ovarian cancer. We know that too many women are taken care of by a specialist who is not a gynecologic oncologist, who's not prepared to adequately perform a radical ovarian cancer debulking procedure, or knows the type of standard chemotherapy we offer to women with ovarian cancer. And then importantly, many physicians carry biased clinical decision-making that definitely impacts care. So some of the strategies to overcome these disparities are to partner again with specialized regional referral centers, increase education and awareness. And what I'm thankful for this meeting is to incorporate health disparities and equity topics into national meetings, to train a more diverse workforce and encourage participation in clinical trials, and not assume that patients are not willing to participate. So as far as patient factors, we know that zip code often determines access to care and poor outcomes if you have a low income, if you don't have insurance, if you don't have access to education. So socioeconomic status is one of the social determinants of health that impacts care. And importantly, what I'd like to focus on is fear and mistrust in the medical establishment. Mistrust of the medical establishment. And we see that being borne out during this COVID pandemic, that somehow we're losing the message in really earning people's trust in us, in medicine and science. So I think it's important for us to focus on developing programs to reach underserved populations, to increase awareness and education, encourage and provide support in the form of peer groups, and to increase culturally appropriate programming and address some of the entrenched ideas based on racism and sexism that we have within medicine and science. So when we think of stereotypes, the example that I gave is that we have a pelvic mass in a Black woman. So you presume or assume that she has a fibroid or a benign tumor. And because ovarian cancer is not as common in Black women, you don't perform a proper workup. Physician stereotype could be that BRCA mutations are not common in Black women. And that is in fact not true. And another stereotype is that Black women are not willing to undergo treatment, so that they may be diagnosed with ovarian cancer, but an assumption may be made that they don't want to undergo radical therapy as far as surgery, or they don't want to undergo cytotoxic chemotherapy treatments. And part of this, countering these stereotypes, are increased awareness and education. Awareness and education about the workup for ovarian cancer and a complex pelvic mass, regardless of race and ethnicity. Awareness and education about BRCA-related and other hereditary cancers, again, regardless of race and ethnicity. Standard of care is if a person is diagnosed with ovarian cancer, we encourage and we recommend genetic counseling and testing. And then really exploring and probing reasons why there's so much fear and mistrust, and why we're presuming Black women are not willing to undergo treatment, and really understanding underlying reasons why, and educating about the importance of treatment in ovarian cancer survival. So I've encountered many patient stereotypes as a gynecologic oncologist, especially when I moved to Nashville, Tennessee many years ago. I heard this, that when air hits it, it would spread, meaning that there were some people who did not want to undergo surgery, some women who didn't want to undergo surgery because they felt that the cancer would spread if you opened up the belly. Some people felt that the diagnosis of cancer would be an immediate death sentence. Some people feel like faith alone will heal, and you don't want to talk about it. So if you mention the word cancer, that means you're somehow claiming it from perhaps a religious perspective. And then many women express the sentiment that they don't trust doctors, and as far as clinical trials, they don't want to be seen as a guinea pig, and they don't want to be a guinea pig. And I believe that there's a lot of work we can do to counter these stereotypes. I think we, first of all, have to acknowledge the street doctors, the lore that exists in our communities, and really understand where that comes from. So I came to understand that when air hits it, it will spread, is that sometimes people were diagnosed with such advanced stages of disease that when they went to undergo surgery, it had spread already, but it was not because of the surgery, it's because of the late diagnosis. I think it's important to really educate people about how ovarian cancer care has changed over the years, even within my lifetime. In the last 2 decades, we've made such advances in ovarian cancer care as far as prevention, risk reduction, diagnosis, treatment, that women are living longer. I think it's important to work with faith communities and church communities to increase awareness about ovarian cancer, and to work with church leaders and church communities to talk about how medicine can work in collaboration with people. And then to train physicians and healthcare providers and healthcare workers to increase trust. And I think part of that is really understanding the history of where this mistrust comes from. So stories matter. This is Chimamanda Ngozi Adichie, is a very wonderful author who's originally from Nigeria. And I really believe that stories matter, especially if we're listening intently to them. And so I'm going to talk about some of the stories that are important to us in medicine. And one of the ways we construct our stories to help patients is to take a history of the present illness. This is a tool we use in medicine to explain, understand, and interpret disease. And we take a history, the patient's chief complaint, why they're here, the history of the present illness, family history, review of systems, prior to performing a physical exam, and hopefully prior to ordering diagnostic tests to help us in making a diagnosis, to offer treatment, and to establish a therapeutic relationship. This is such an important part of what we still do in medicine to date, even with all our advanced technology. But I think we run into problems if we don't believe the story or the storyteller. So I'm going to tell a story about the speculum, syphilis, cervical cancer, and Serena Williams C-section. And please bear with me because these topics are related. So the modern speculum was developed in the late 1840s in America. And I'll tell a story about an 18-year-old Black woman. She had given birth to a child 2 months ago, and since that time had been unable to hold any water. Her bladder was destroyed, leaving an opening between the vagina and the bladder at least 2 inches in diameter or more. This is taken from Dr. J. Marion Sims' own writing, and he talks about that was before the days of anesthetics. The poor girl on her knees bore the operations with great heroism and bravery. I had about a dozen doctors there to witness the series of experiments that I expected to perform. All the doctors had seen my notes often and examined them and agreed that I was on the eve of a great discovery, and every one of them was interested in seeing me operate. So Anarcha was one of the enslaved Black women Dr. J. Marion Sims operated on, and she underwent 30 operations approximately, at least ones that he reported, for fistula repair. And he proposed to the owners of Negroes, in his own words, "If you will give me Anarcha and Betsy for experiment, I agree to perform no experiment or operation on either of them to endanger their lives and will not charge a cent for keeping them. But you must pay their taxes and clothe them. I will keep them at my own expense." This was in 1884. The story of my life is when he wrote this. And he developed the Sims speculum to help with fistula repair surgery. So Anarcha, Betsy, and Lucy were the three enslaved women he mostly talked about, but he operated on many enslaved women without their consent to perfect his surgeries and to design his speculum. So before I go on to the next story, I want people to reflect on that this history of mistrust with medicine goes way back in our country to days of slavery. The next story is about the Tuskegee study of untreated syphilis in the Negro male. This study went on for 40 years, from 1932 to 1972. So in this study, 600 Black women, 399 with syphilis versus 201 without syphilis, no informed consent was obtained, were studied. The men thought they were being treated for quote unquote bad blood. And in exchange for taking part of the study, they received medical exams, meals, and burial insurance. And although the originally projected study was to last 6 months, it went on for 40 years. And basically it went on even after we had a treatment for syphilis, which is penicillin, and the men in the study never received treatment. So the study was eventually halted after the Associated Press identified it. A $10 million settlement was reached to the Tuskegee Health Benefit Program. Wives, widows, and offspring were added, and the last participant died in 2004. The last widow received funding from this program in 2009. So this is actually recent history. And we think about people being mistrustful of the government, and now it's so important because we're in the middle of a COVID-19 pandemic. And so when we think about this picture in the upper right of your screen where a man is actually getting his blood drawn, it's very hard to convince people that perhaps he wasn't being injected or infected with syphilis. So the Tuskegee experiment is quoted as one of the main reasons many people have vaccine skepticism. African American and Black adults are less likely than non-Hispanic white adults to have received the flu vaccine in the past year or the pneumonia vaccine ever. And Black women are 10% less likely to have received an HPV vaccine compared to white women. So that study, done decades ago, has lasting impact on healthcare now. So this is a story about HeLa, Henrietta Lacks, a Black woman's cervical cancer cells and biomedical advances, 1951. So this is a 31-year-old Black woman who presented reporting pelvic pain, postcoital bleeding, bleeding after sex, and foul-smelling discharge, and a knot in her womb. She was diagnosed with inoperable early-stage adenocarcinoma of the cervix and treated with radium implants. She died of disease within several months of treatment and within a year of delivering her 5th child. So Mrs. Henrietta Lacks, a book was written and a movie starring Oprah Winfrey became a household name, but originally these cells were had a pseudonym, Helen Lane or Helen Larson, HeLa cells. These are a remarkably durable and prolific line of cells. This is the first immortalized cell line created at Johns Hopkins from Mrs. Lacks' cancer by Dr. George Gay in 1951. These cells, HeLa cells, have gone on to be critical in in helping us advance medicine and science, including contributing to the development of the polio vaccine, the human papillomavirus vaccine, and cancer treatments, cancer therapy, on and on. And so when we look at medical practices of the 1950s versus today, some people would argue that we should not impose our own moral judgments on previous history. And I suppose that argument could be made for the 1940s and 1930s and the days of slavery. But I would counter that argument with saying that did anybody ask the people that these medical practices were being performed on, and would they agree that that the care was adequate? So in the 1950s, there was no established practice for obtaining consent or informed consent. And current practices today, with all sorts of research, is that we have human subjects oversight, institutional review boards, and we obtain informed consent. Collecting patient samples for research was common practice without consent, and this was regardless of race or socioeconomic status. And today, we have lots of regulatory and legal standards and oversight. But I would still say that even though it was not common practice, I'm sure people would have wanted to have been given the opportunity to have a say as to what was going on with their cells and their tissue, even in the 1950s. And then again, with medical practices in the 1950s versus today, Johns Hopkins Hospital was one of the few hospitals that actually was open to treating Black African-American patients. But once they entered the halls of the hospital, patients were segregated. And so although Mrs. Henrietta Lacks received standard of care radiation treatment at that time, she was treated in a segregated ward. So Johns Hopkins did not fully desegregate until the late 1950s, starts desegregating until the 1950s, late 1950s, and into 1973. So again, this is recent history. And then if you think about socioeconomic status overlapping with race, a lot of our hospitals and clinics and healthcare systems are segregated in many ways by zip code and by setting. So some of these trends of medical practice from the 1950s persist today. So if we think about why the story of Mrs. Henrietta Lacks is so relevant to Black women and cervical cancer, Black women are less likely to receive HPV vaccination, more likely to be diagnosed with disease, more likely to be diagnosed at later stages of disease, and less likely to receive standard of care treatment when diagnosed. All of these lead to Black women being more likely to die of cervical cancer than white women. So I'm going to end my series of stories with Serena Williams' C-section in 2017. This is a 36-year-old Black woman. She had a history of a pulmonary embolus in the past and delivered a healthy female by emergency C-section for decreased fetal heart rate. The day after surgery, she felt short of breath. She was off her daily blood thinners, anticoagulant regimen due to the recent surgery. She told the nearest nurse between gasps that she needed a CT and IV heparin right away. The nurse thought her pain medicine might be making her confused. The patient insisted, and soon enough, a doctor was performing an ultrasound of her legs. Quote, "I was like a Doppler. I told you I need a CT scan and a heparin drip," she remembers telling the team. The ultrasound revealed nothing, so they sent her for the CT, and sure enough, several small blood clots had settled in her lungs. Minutes later, she was on the drip. I was like, listen to Dr. Williams. The next day, her fresh C-section wound opened from the intense coughing spells caused by the pulmonary embolus. And when she returned to surgery, they found a large hematoma, large blood clot had flooded her abdomen. She returned yet again to the OR to have a filter inserted into a major vein to prevent more clots from dislodging and traveling into her lungs. So this is Serena Williams, and the story is from a cover of Vogue magazine. There's her little beautiful daughter, and the outcome ended up great. She's ended up doing well, and she's back to playing tennis and has a match against her sister, Venus Williams, today. But the two conditions we have here, the leading causes of pregnancy-related death in the United States are hemorrhage, bleeding, and blood clot. And Black women are 2 to 4 times more likely to die in childbirth than white women. And this story resonates, Serena Williams' story resonates with so many Black women, resonated at the time and resonates today. She is the greatest of all time tennis player, and she's this huge celebrity. And if people didn't listen to her, what does that mean for the rest of us? And as a personal anecdote, I remember when I was delivering my baby, people did not know I was a doctor, and I was an OBGYN. I delivered babies myself at that time, and how vulnerable I was and how it was difficult for me to advocate for myself. My husband tried on my behalf and did a great job, but it made a huge difference to have my OBGYN, who's a Black woman doctor, come in and navigate for me, because the interactions and the assumptions people made about me as a Black woman were prejudicial, and there was a lot of unconscious bias, and she was able to step in and really set the tone, and I received better care because of that. So one of the unfortunate legacies of Dr. J. Marion Sims, who is considered to be the father of gynecology, which is a field that I'm in, is that he operated on so many of those enslaved Black women without anesthesia, even when later in history anesthesia was available. And so this led to a persistence up till today that people think that Black people's nerve endings are less sensitive than white people. So we see this borne out in labor. We see this in pediatrics, where Black children who have pain from appendicitis are not given pain medicine at the same rates as white children. We see this with sickle cell disease, with Black people who have sickle cell disease are not given as much pain medicine. And so this is something that persists. So you can imagine if you have ovarian cancer as a Black woman and you have pain from your disease, are you going to get the same treatment as a white woman who has pain from her ovarian cancer? And these are persistent biases that really are racist ideas that are in the field of medicine that we have to get rid of. This is a study that looked at the lay public, but also trainees. And what's interesting from this study is that many of our trainees, our residents, had similar opinions about some of these, frankly, racist views about Black people and medicine. So what I hope to show you through these stories that don't seem related, but are that Black women's distrust the medical establishment is supported by historical and current data and personal narratives, lived experience. So as a gynecologic oncologist and a physician scientist, with so few of us in the field, I've personally experienced anti-Black racism during training, during my training, and I've experienced it as a patient. What we see from the stories that I've told is all of the women and all of the people, including the men in the Tuskegee study, received some form of medical care. But what I want us to think about is how they received their care, what form, and how it was experienced and perceived by the people receiving it. And what I worry about is we don't even ask. Did we ask? Did we listen? We don't have firsthand accounts of Lucy, Anarka, and Betsy who underwent these horrific surgeries without anesthesia, because they were slaves. They were enslaved people. Nobody asked. You know, even though the men in the syphilis Tuskegee study thought that they were participating in one thing, even though they agreed to participate in the study, I'm not sure they really understood and were given the proper information about what that study was. And when treatments became available, they did not receive the treatment. I think taking tissue, cells, body parts without consent is something that's really changed how we do medicine. We have to reassure people that really we have oversight, we have informed consent, and that we need to honor that, and we need to be true to what we've designed to counter this area of mistrust. And then what's really important, and I think this is relevant to advocates in all areas of healthcare, but in particularly cancer care, it's important to listen. And I think Serena Williams' story, my own story, and countless others show that we have to take a moment, stop, and listen to the patient who's telling us what she knows best about her lived experience, about her own body. So those are the sort of historical and lived experiences stories, but I want to kind of go back to a bigger picture that there's societal costs to inequities, deep societal costs that not only cost us from a moral standpoint and an ethical standpoint, but also cost us excess costs financially, an excess burden of disease, and an excess cost in increased healthcare costs to people who are diagnosed with later disease. And so it costs less for risk reduction and prevention than it costs for treatment. So that's something important to think about. So my call to action as I wind down is for us to find ways to change the narrative. This was a couple of years ago, the controversial statue of J. Marion Sims was removed from Central Park in New York. And this was very controversial because many people felt that it should stay. But many Black women were outraged that we're honoring a person who did not really truly, and from many Black women's point of view, did not believe that the women he was operating on were fully human. And I think that this is what we're seeing right now is that, believe Black women, not more than anybody else, but just as much as anybody else. And we need to ask and listen and believe. Because I can't imagine that any one of those women would have said that their pain and suffering from their surgeries was, I can't imagine what they went through. So I think it's important to listen to Black women. And if you listen to Black women, I think you're going to know how to listen to all women. History is important, especially when we can learn from it. Stories are important tools to remind us of our humanity. And in medicine, we need to be very careful. We need to not present cases because each medical case is a real person behind that case. We can change the narratives and the ecology of healthcare from a workforce standpoint and from how we can do better in treating our patients. And we can engage communities in our own health. And so that's why it's so important to have conferences like this, where we're advocating for our own health. One group that's in the endometrial cancer world, which I would encourage people to take a look at their group, is the Endometrial Cancer Action Network for African Americans, and it's a peer focus group. And what they've done a lovely job with, and they work closely with Dr. Kemi Dahl, who's a gynecologic oncologist, is to demystify some of the issues of being diagnosed with endometrial cancer and undergoing treatment. And I think one of the most important factors is that therapeutic relationship It's important to make peace with your doctor. So if you are not in a good therapeutic relationship with your doctor or your provider, it's important to get a second opinion and to find somebody who you're comfortable telling your story to, because that's how you're going to get your symptoms addressed in an adequate way, and get the best care possible. So I would hope that we could develop similar peer groups and focus groups within our ovarian cancer advocacy community. The other thing that's so important to me is that we need to train more Black doctors, nurses, and healthcare workers. Nearly 1/3 of oncologists are women, so we need more women to go into oncology. Only 2.3% of practicing oncologists are self-identified as Black or African American, so it's only about 2% of the population. And only 7.8% of nurses are Black. So I think that we have a workforce issue that we need to address to increase the number of people going into these fields so that we better reflect our patient population we serve. And then finally, research. I was so excited to see that there are 3 ovarian cancer studies aimed to reduce racial disparities to hopefully improve outcomes. And these were just announced in the past couple of months. There are 3 major groups that are focused on understanding underlying racial disparities in ovarian cancer care and treatment. So I believe we can eliminate ovarian cancer inequities. I believe that we need to continue doing what we're doing as advocates, and the advocacy community in ovarian cancer is so powerful and so strong. And so these principles apply to Black women and all women who've been affected by ovarian cancer as survivors and advocates. And I think what we talk about is that we need to listen to women. And one of the big landmark studies in ovarian cancer was to actually listen to women diagnosed with ovarian cancer. And what women said loud and clear is that ovarian cancer is not a silent disease. It is not silent. There are symptoms, and these are the symptoms, and we just need people in medicine to listen to us. We need more funds for ovarian cancer care and ovarian cancer research. We need our politicians to listen to women so that we can prevent ovarian cancer and find a cure. We need to look carefully, listen carefully as healthcare workers, providers, take detailed history, listen, perform appropriate exams and tests that we know are related to diagnosing ovarian cancer, not assume a person has fibroids because they're a Black woman with a mass. We need to learn about our family histories and the importance of taking good family histories if we're in healthcare, and encouraging cascade genetic testing so that we can intervene with risk-reducing procedures in families who have, for instance, a BRCA1 gene mutation. And then we need to do a lot of work around building trust in these therapeutic relationships and therapeutic partnerships. I think one thing that Black women can inform medicine about is that we're very much interested in collaborative care. The physician, the provider, has expertise regarding medical knowledge, scientific knowledge, and the lived experience. And the patient has expertise with self-knowledge and her lived experience. And those 2 things together need to be respected and listened to so that we have a therapeutic partnership and relationship that leads to the best outcomes. And so I would propose to you that eliminating racial inequities in ovarian cancer care is imperative. It is the right thing to do from a moral standpoint. It makes economic sense so that we don't burden our healthcare system with excess costs. And in fact, if we take care of the most vulnerable of us, the people who are getting the least amount of care, and we know how to do that well, it elevates the care for everybody, makes care better for all. And so I really want to thank the OCRA. I'm encouraged by the statement that was made earlier based on the events after the George Floyd murder, that Black Lives Matter to OCRA. I want to sincerely thank OCRA for helping me personally in my own career. The first grant I ever received was from OCRA, and that launched my career. That's allowed me to become a gynecologic oncologist, a physician scientist, and now the chair of a department of OBGYN at Washington University in St. Louis. So I thank everybody for their time and their attention. Let's get to work.